This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken with prior written consent of the AARC only. Copyright 2011, all rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services, and I welcome you to today's webcast on disruptive behavior, a threat to patient safety. Upon completion of this webcast experience, you should be able to describe disruptive behavior as a threat to patient safety, explain the impact of disruptive behavior, describe the Joint Commission recommendations regarding disruptive behavior, and describe common errors in managing disruptive behavior. I am pleased to introduce David Gourley. Dave is a registered respiratory therapist holding an NPS credential and an AARC fellow. He has also earned a master's degree in health administration. He is currently the executive director of regulatory affairs at Chilton Hospital in Pompton Plains, New Jersey. Dave is also an adjunct professor on the faculty of Seton Hall University. He is a frequent presenter on the subject of patient safety at state and national conferences. Mr. Gourley discloses that he has no conflict disclosures related to this presentation. Brand names may be used as examples of technology. Dave, welcome to the program.
Thank you, Bill, and it's my pleasure to be here today to speak on this important and timely topic in healthcare that all of us should be very concerned about. When we talk about disruptive behavior, the things I want to cover today in the period of time of this conference is, first, what is disruptive behavior? I'll then give some examples of disruptive behavior that probably many of us have seen in our practice over the years, and then speak about the impact of disruptive behavior on quality of care and on patient safety. I'll then talk of some of the barriers to reporting disruptive behavior, look specifically at physician disruptive behavior, which is the area many of us think this lies solely, but truly disruptive behavior also does happen within and between disciplines, so we'll speak about that also. I'll then speak about the Joint Commission expectations for handling disruptive behavior, speak about the Code of Professional Conduct, which we should all have in place in our institutions at this point in time, and go over some of the ways to manage disruptive behavior and some of the common errors used in managing disruptive behavior. I'll close with some words of wisdom, which are should be common practice for all of us in all of our activities. And lastly, there are some references included in case any of you would like to refer to additional materials on this topic, which, as I say, is important to all of us. Disruptive behavior has shown to have a negative impact on staff relationships, on team collaboration, communication flow, and on patient outcomes. This can and is a major factor in adverse events. Certainly some of the changes we are seeing in healthcare these days have an effect on all of us, and some of the more seasoned clinicians, whether that be respiratory therapists or physicians, are affected by these changes, and they have a major impact, I believe, on why we see disruptive behavior increasing in the healthcare world today. So what is disruptive behavior? It is a behavior that interferes with our ability to provide safe and effective care to patients, which obviously is our goal. It undermines the confidence of other team members. So when we have disruptive behavior, other team members' confidence will be diminished, and their ability to function as a quality practitioner will be diminished. When patients or patients' families witness disruptive behavior, it will undermine their confidence in the healthcare system and in our institutions. And it is a cause of concern for physical safety in some of the most extreme cases of disruptive behavior. So staff members, our employees, may feel that their physical safety is at risk. And it does undermine effective teamwork, as I mentioned. Some of the typical examples of disruptive behavior are use of profane language, abusive language, name-calling, use of sexual comments, use of racial or ethnic jokes, showing sarcasm or cynicism in our conversations, outbursts of anger, throwing of objects, public criticism of others, of either of our peers or of others who may be below us in the organization, blaming or shaming of others who are involved in adverse outcomes instead of being supportive when our coworkers may need our support. Intimidation that suppresses input from other clinicians. So where the situation where maybe a respiratory therapist would be afraid to put a call out to a physician because they're afraid of what the conversation will be like on the phone or what the reaction to that conversation would be. Or they're afraid to ask for assistance from a coworker, or they're afraid to approach a supervisor with a clinical issue because of the intimidating behavior they've witnessed before. Failure to adhere to policies and procedures, what I might call the rogue therapist who is off doing his own thing, his or her own thing. And lastly would be retaliation against clinicians who raise concerns about safety. As we're all aware, we should all feel very comfortable to report safety, patient safety issues up the chain of command in the hospital so that they can be dealt with in an appropriate manner. And if there is a staff member who feels that we are reporting them personally versus reporting a patient safety issue, that can again lead to retaliation, which would impede a clinician's ability to provide safe and appropriate care. So where do we look for disruptive behavior? Well, we don't have to go any further than our own living room and watching TV as we watch some of the shows that we see. Certainly ER, which was a melodrama set in Chicago, was the longest running medical drama on for 15 seasons. If any of you have watched that, which I'm sure many of you have, we've all seen some disruptive behavior, whether it be slamming of charts, throwing of objects in the ER, and then of course the personal drama that came through in that show on an ongoing basis. And then we have House, which is still playing on TV, based right here in New Jersey in that fictional show where he clashes with other physicians, clashes with team members, disregards the rules, is known for substance abuse. And all of this makes for great TV, but it certainly is not appropriate in today's healthcare setting. So some examples of disruptive behavior that apply right to the respiratory therapist. You have the pulmonologist who gets the phone call from the respiratory therapist and refuses to come to see the patient. So the respiratory therapist is told it's not their job to think, it's just their job to follow orders. And then treatment to that patient's delayed. That patient winds up getting intubated and placed on a ventilator where that may have been avoided if the pulmonologist would have responded appropriately to that respiratory therapist's call. And then the scene that we most commonly think of when we think of disruptive behavior is in the surgical suite, where the surgeon is in the OR and is told that the surgical sponge count is not correct. And the surgeon says they'll find it later, closes the patient, and then the patient has to be reopened at a later point in time to retrieve a sponge that was left in the patient during surgery. Or we have the physician that berates the respiratory therapist during an intubation procedure because he doesn't feel the laryngoscope was given to him quick enough, hurls the laryngoscope across the room at the respiratory therapist and storms out of the emergency department. So these are all just 3 examples of what is a much larger problem there that we see with behavior of this manner that we consider disruptive behavior. This is the disruptive behavior pyramid. And what we're kind of showing here is the level and amount of disruptive behavior that we see actually in hospitals today. Most of us fit right here, and that's that we're models of professionalism. We really don't have any issues with disruptive behavior. We come to work every day doing the best we can for our patients. We're respectful to both our peers, those below us in the organizational structure, and certainly those above us, the physicians and other professionals that we're working with. We might have a single unprofessional event at some point in time. And what would need to be done here is what we call informal intervention. So informal intervention would basically be, let's sit and talk about what happened during an event today. And maybe for this person, it's just they had a bad day, something happened at home on the way in, maybe there's some personal issue going on. But this person is normally a professional, but on this one single event had an unprofessional event. Many times they may not even be aware that they were being disruptive when this event occurred. So they might not even realize the way that they were received by the person that they interacted with. Most of the time they'll be very apologetic once it's brought to their attention that this behavior was perceived as disruptive to the other professionals that they worked with. Moving up the pyramid there, we then have a person or a clinician who has an apparent pattern of disruptive behavior. So they haven't had just a single element, but over time, whether it be on a fairly frequent basis or very sporadic, have had repeated events where they have exhibited disruptive behavior. And what we need here is what we call awareness intervention. And that would be some appropriate education and training for that person, maybe on relationship building, good communication skills, depending on the type of disruptive behavior. They might need some anger management or stress management training. When this persists, if this pattern persists, the person is obviously moving up that pyramid further. And as you see, there's a less and less number of clinicians that are fitting into these categories. Luckily, we're not seeing people reaching to this level on a very frequent basis. But we certainly do have those who persist with this pattern of disruptive behavior even after it's been brought to their attention and had some sort of training and education on preventing or minimizing this behavior. So at this point, we really need to have authority intervention, and that might include having coaching models or mentors or setting up a buddy system with this practitioner so that that person can help to monitor their behavior and help to remind them when maybe they're escalating to a point where they're going to move into a disruptive behavior situation. So what we're trying to, of course, is prevent from reaching that last level on top where a person does not change, and we need to begin the disciplinary process and have disciplinary intervention. And that can be anything from your typical suspension or up into the point of termination. So the person may be terminated or their privileges at the hospital discontinued as a result of this ongoing pattern of behavior that seems to not be able to be changed. So the impact of disruptive behavior, what is the impact that it has both on patient safety and quality of care? First, withholding information. When a clinician knows that they have to communicate with a practitioner, whether it be a physician, another therapist, a coworker on their shift, or a nurse that's in a unit, a nurse manager in a unit that they need to work with, and they have had some experience with disruptive behavior in the past, they may withhold information. And withholding that information is actually going to be harmful to the patient because that clinician is going to be making a decision in their mind, is this situation important enough, is this information urgent enough that I want to go interact with this person that I've had a negative reaction from before. So there may be those times when you have critical information about a patient that needs to be transmitted to the physician, the nurse, whomever the clinician is, that we're withholding because we just don't want to interact with that person. The staff may cover up for mistakes. If the staff does not feel comfortable coming forward and saying that there was an error made or there was a complication or there was some sort of some sort of issue, an adverse event, they'll cover up for that rather than bring that forward to their supervisor or to the manager of the area so that can be addressed. So instead of being open and honest with patient safety issues, they're covering them up. All of this can lead to a reduced initiative by that therapist, so the therapist won't be working at the level they should be, reduced morale among staff, which obviously is a employee satisfaction and employee engagement issue, reduced self-esteem for that person, so not only does it affect them in their professional function, but it also might affect them in their personal life. Staff dysfunction, we're not working as a team, and obviously we know that teamwork is essential in healthcare. We're not functioning as independent practitioners there, we're functioning as a healthcare team. Increased turnover, which has an extremely high cost to your institution and is a dissatisfier to the rest of the coworkers when there is turnover and you need to have either work short-staffed or work with temporary help that isn't used to your institution. So all of that can have a negative effect on your department. Increased absenteeism. If a staff member knows that they have to work with a coworker that they've had negative behavior issues with in the past, they may use that time to call in sick, take their time off during that so they don't have to interact with that practitioner. Then leads to chronic complaints that the manager then has to be handling the complaints instead of handling the clinical issues they should be. leads to incomplete communication, and we know that communication is either a root cause or a contributing factor whenever there is an adverse patient event. So incomplete communication certainly is a big concern with patient safety and disruptive behavior. Inadequate teamwork, as I mentioned, we need to work as a team. It's essential that we work as a team both within our department and with our nursing colleagues and physician colleagues. So when we have inadequate teamwork, it certainly is a risk. The risk of litigation, any patient safety issue, any patient safety event or adverse event does bring with it the risk of litigation. So it just is common sense that disruptive behavior leading to patient safety issues will increase our risk of litigation. And lastly is increased time putting out fires. So whether that be the staff, the supervisor, the manager of the department, or administration, time putting out fires and dealing with these disruptive behavior events takes time away from the more important goals that we have for our institution of our strategic goals and our clinical goals and clinical improvements. So the impact on administration. As I mentioned just a few minutes ago there, the increased risk of litigation. So there is truly an increased risk of lawsuits when we do have a significant amount of disruptive behavior that is affecting quality of care and patient safety. Increased time being spent with disgruntled staff and patients. And certainly when we are spending time with people who are unhappy, that's taking time away, as I said, from spending time doing the more important things that we need to do. So disgruntled staff, unhappy patients, unhappy families are just taking time away from more important issues. Leads to reactive public relations. Certainly all of us know how important it is to have a positive public image in our institution, and for us to maintain that, we certainly don't need press getting out about disruptive behavior happening in our hospital. Can lead to recruitment and retention issues. We know that respiratory therapy is a small field, and a lot of people, we know each other, and the message gets out if there's a particular hospital where either the physicians are not particularly open to respiratory therapists, or the department is a department where there's a tough crowd in that people wouldn't want to work in. This does lead to retention issues in that department, and then further recruitment issues. And lastly is conflict management. When these issues do continue to rise to the surface, the administration has spending time in conflict management. So why don't people report disruptive behavior? And certainly that is one of the big issues with the whole issue of disruptive behavior, is that many times the management staff or administration isn't even aware that disruptive behavior is occurring. So this is a poll that was done of physicians, nurses, and all other clinicians, which included respiratory therapists. And the number one reason why clinicians don't report disruptive behavior is because of the feeling that nothing changes. And probably most of us aren't too surprised by that, because many times you do hear that people are reluctant to report something, or just don't report something that is wrong because they feel it's not going to make a difference anyway. So certainly we need to change that perception and that attitude, because if we don't know disruptive behavior is happening, we really can't do anything about it. The second most frequent reason for not reporting is that there's no feedback, and that's something entirely in our control if we're the ones investigating disruptive behavior. The person reporting a disruptive behavior event should get some sort of feedback that there was action taken, and that their concern didn't kind of fall into the proverbial black hole, and that we just ignored it and didn't do anything about it. Obviously, we do have the confidentiality issues regarding the practitioner who's involved that we have to respect. So we certainly may not give all the details of what occurred to, say, a physician that's reported for disruptive behavior. But what we have to let the person know who's reported it, that their concern was taken seriously, has been investigated thoroughly, and that we have taken appropriate action based on the situation that they reported to us. Next down the list is fear of retaliation. And as you see there is a significant number of people that believe there is a potential for retaliation if they report an incident of disruptive behavior. And that is something also that we should be concerned with, because I've heard that myself, where people have been concerned that if they did report a clinician for disruptive behavior, that there may be some either physical harm or harm to their property for that. Next is lack of confidentiality, so that the staff is afraid if they report something that we're going to use their name when we speak to this clinician about their outburst of anger or whatever the disruptive behavior was. So certainly it is encouraged that we do have a confidential reporting. Some situations it's not possible to not know who reported it because it may be between just two people. But certainly there's many times witnesses to this behavior, and many of those people do have the ability to then report that and also for action to be taken. There was a survey done of the types of disruptive behavior, and the most common type of disruptive behavior was condescending language or tone. So as you see, it's not that outburst and throwing of the laryngoscope. It's basically just a poor interpersonal relationship between that person with a verbal tone that is intimidating to that person. Next is impatience with questions, and certainly we want to feel open and honest and be able to ask the questions that we need, especially when it's regarding a patient's condition or treatment of a patient, and we wouldn't want to feel that that impatience is impeding that. Next is reluctance or refusal to answer questions or calls. The physician that you call 2 or 3 times never calls back or refuses to get on the phone if you call their office. After that happens multiple times, are we going to attempt again to call or just avoid that telephone call? Strong verbal abuse, again getting to the verbal affronts that we have, and then threatening body language. So it doesn't even have to be verbal. It can just be some sort of threatening body language that will be intimidating and impede that person's ability to perform. Next is, are there any specific medical specialties where disruptive behavior occurs? And it's probably not surprising to you that some medical specialties do have a significantly higher number of disruptive behavior events than others. I'm happy to say that we don't see the pulmonologists anywhere on this, and in my career I think that pulmonologists are one of the easiest medical specialties to get along with. Probably as respiratory therapists we have a very common goal and are on the right same thought process, but certainly we should be with some of the other physicians too, and we don't see that same collegiality with these other professions. So as you see there, general surgeons are the #1 specialty reported for disruptive behavior, followed by neurosurgeons, cardiovascular physicians, orthopedic surgeons, anesthesiologists, and OBGYN. Next question asked was, how often do we see problems with physician behavior? So how often are there disruptive physician behavior incidents reported? And the most common as we see is that we can see that there are many that are reported daily, weekly, or monthly. So if we look at those 3 categories on the bottom of the screen, we do see that over 30% are reporting that at least monthly there are incidents of disruptive behavior. So that to me is concerning, that 1 in 3 people who were asked said they'd seen at least monthly periods of disruptive behavior, up to the less frequent of more than 5 times a year to 3 to 5 times a year, which is at almost 25%, and then once or twice a year being at only 17%. Sad to say that there's only 4% that say they never saw an incident of disruptive behavior. I'm assuming that majority of people on the conference today have seen it, and that's why it's a concern to them, because they at some point in their career have witnessed disruptive behavior. Okay. Who's responsible for the physician disruptive behavior? So the question here really was looking at, is this widespread? Is it across the board that there's just something inherent with physicians that they are going to be disruptive? Or is it more specifically a group of physicians? And the answer to here, as you see, 70% of the respondents said that it's nearly always the same physician or physicians over and over again that are responsible for disruptive behavior. And less than 30% said it does crop up among various physicians from time to time with no clear pattern. So by and large, we should be looking, when we find those physicians that we're having issues with, if we take care of them and address them, that should take care of the greatest majority of our disruptive behavior that we're seeing in the workplace. Who is this disruptive behavior between? We know it's, and we're talking now about the physician. So who are they conflicting with when they exhibit this disruptive behavior? So over 50% of the time it's a nurse or another healthcare professional, so that certainly is a respiratory therapist. So nurses or respiratory therapists are the recipient of the physician disruptive behavior over 50% of the time. 15% with another physician, which many of you may be surprised at. With administration, about 15%, and a patient or patients, which to me is should be very surprising that the physician would be disruptive or have this type of conduct with one of the patients that's actually they've been asked to treat. But certainly that is being reported in almost 15% of the cases. The next question asked was physicians in your organization, so looking specifically at your organization, and how are they treated when there is an incident of disruptive behavior? Because the thought is that the physicians are treated more leniently than the hospital staff, so nurses, respiratory therapists, etc. So looking at this poll here, 27% said that the physicians were treated exactly the same as other employees when there was a behavioral problem. 63%, so we could say essentially 2 out of 3, are saying that physicians are treated more leniently than others because of their professional stature. And all types of issues come into that. How much business does the physician bring into the hospital? Where do they sit with the board of trustees? How close are they to administration? All of those issues come into play. But what we really need to see as we move through this is that physicians need to be treated in the exact same manner that any of our hospital would be staffed would be treated in the same exact position. 9% say, though, that the physicians are treated more harshly and are held to a higher standard of behavior than other employees, which was very interesting to see. I did speak with a physician down in Tennessee who's one of the leaders in this whole movement of addressing physician disruptive behavior. And he said to me, he says, we don't have any physicians with disruptive behavior at our hospital. He said, we send them to yours. We get them off our staff, and now they're practicing somewhere else. So certainly someone, if you have a physician leader that's holding to that high standard, you may wind up in this 10% at the bottom of the screen. The next question asked was, in the past 2 years, what action was taken to address disruptive physician behavior? And as you see that 31% was trying to ignore the problem, and we're certainly going to talk about that with some of the challenges of addressing disruptive behavior, of not taking any action and hoping and praying it will just go away. 94%, which is great to see, that actually the physician was met with and discussed the behavior, so that at least it was brought to that physician's attention. Whether it made improvement is the next step we'd want to see, but it is good to see that in the large majority of cases, the physician's behavior is being at least discussed with that physician. In 2/3 of the cases, they were issued a written warning. Half the cases asked to seek some sort of behavioral counseling, which certainly is one of the things in extreme cases of disruptive behavior that we would want to encourage. And then 1/3 reported that a physician had actually been terminated for disruptive behavior. So obviously many hospitals are taking this very seriously. As I said, we can think that it's just physicians and talk about how horrible disruptive behavior is with physicians, but it is not exclusively for physicians. There is disruptive behavior within disciplines and between disciplines. So this book here, Ending Nurse-to-Nurse Hostility, and the subtitle is Why Nurses Eat Their Young. And certainly we have heard that term if you've been in healthcare a while, that the toughest people on new nurses are more seasoned nurses. And we call that horizontal hostility. So it's hostility on the same level on the organizational chart. And this can occur for many different reasons, that we do have these challenges and these conflicts between our coworkers. Cliques develop, that's part of human nature, that you'll have cliques or subgroups within any particular group. So within a department, you'll have cliques, you'll have the group of people who hang out together on the weekends or socialize together outside of work. In addition, we have the generation gaps, and certainly today we probably have 4 different generations working in the workplace together, all with different cultures that they grew up in and different ideals and beliefs that can lead to conflict within the workplace. Then we have the middle manager stuck in between. They're not really fitting into administration or to the senior level, and they're not really staff people either, so they kind of fall into that middle section there where they're not quite sure at any point in time, are they part of the staff and should they be functioning that way, or are they part of management? And then we have the need for mentoring for new staff. New staff come into the hospital, and we have to look at what's our orientation and mentoring process like. And are we patient enough with our new staff that comes into the hospital so that we can mentor them and get them to function in the way that we want them to. We have to look at what management's role is in managing the staff when they do come into work, whether it be the new staff or mentoring our old staff to be able to handle that appropriately. And then looking at overall organizational opportunities to have better work groups together and have better teamwork. So what are the frequent forms of horizontal hostility? The nonverbal innuendo, so the therapist who's giving a report to the next shift, and that therapist is sitting there not looking, doodling on paper, maybe text messaging a friend or looking on the internet on their cell phone, and not really paying attention to what that other therapist, the important message that therapist is trying to give to them. Or the verbal affront, where someone will lash out verbally at one of their coworkers. Undermining their activities, so maybe following up and talking to staff on a unit they're working with and disparaging comments about them. Withholding information, so important patient information that might need to be given, and they're withholding it from that person because of this interpersonal conflict. Sabotaging either the work of that person or something personal with them. Infighting within the department, making a scapegoat out of one of your coworkers, backstabbing between people within the department or again with other allied professionals in the hospital. Failure to respect somebody's privacy, so bringing in maybe personal issues or outside issues and that you know about and revealing them within the hospital when that was under confidence that was brought in, and then broken confidences for someone maybe that revealed something of a personal nature or a private nature to you. The Joint Commission addressed the whole issue of disruptive behavior with a Sentinel Event Alert back in 2008, so just almost 3 years ago now. And for those of you not familiar with this Joint Commission Sentinel Event Alert process, periodically the Joint Commission issues these Sentinel Event Alerts based on sentinel events that have been reported to the Joint Commission, and then looking if there's commonality between events and they feel that there is something of a significant enough nature that they need to then release out to the healthcare community so that we can all learn from events that have happened in other institutions across the country. So on July 9th of 2008, the Joint Commission issued Sentinel Event Alert number 40, which described intimidating and disruptive behavior. It included many of the root causes and contributing factors to this behavior. And then they included in that a new leadership standard that's included in the Joint Commission Standards Manual now and is surveyed during Joint Commission survey. And that standard requires that the hospital or healthcare organization develop a code of professional conduct that defines acceptable and disruptive and inappropriate behavior. So not only does the code of conduct have to tell us what we should be doing, but it has to specifically outline what is unacceptable or inappropriate behavior. So it clearly states the things that we should not be doing. In addition, the next element of performance says that leaders have to create and implement a process for managing disruptive behavior and inappropriate behavior. So it is not only expected that we have the code of conduct but that we actually implement it over time. There is an additional medical staff standard addressing physician disruptive behavior, and it includes looking at interpersonal skills and professionalism among the medical staff. In addition, we want to educate all our team members, and we're looking here again at physicians and the ancillary staff, the clinical staff, and the support staff. We want to educate them in all interpersonal skills, basic business principles, phone skills, different people skills, and just proper etiquette. We need to hold all our team members accountable, and we need to be equitable when we're holding them accountable. So we need to be reinforcing our positive behaviors, and we need to be disciplining when necessary. We need to implement the policies and procedures that have been developed in regards to disruptive behavior, and we really need to set a zero tolerance policy, which means that one incident of disruptive behavior needs to be addressed. We don't ignore it until it happens repeatedly, whether it be weekly or monthly like that one chart showed. Medical staff policies need to be developed, so that's part of looking at the medical staff bylaws and how in your institution they're handling disruptive behavior. And we'd also want to look at employment agreements for physicians and for other ancillary staff and contracted employees that might be brought into the hospital. You might have some employees that are not direct employees of the hospital but are hired under contract, and they should be held to the same standard. We need to be able to reduce fear of intimidation and retribution. So we do have to have a non-retaliation clause in our policies so that it would be completely unacceptable and further action would need to be taken if there was any retaliation for reporting someone for a violation of the code of conduct. We have to respond appropriately to patients and families. As I mentioned briefly before, the patient and or family members may be witnesses to this disruptive behavior even if they were not directly involved in it. So an outburst in a nurse's station, an outburst in a hallway or an elevator where a patient or family can see that, we should be responding to those patients and families so they're not walking out with that negative image of our institution. And then we need to look at when to implement our disciplinary actions, so whether it be suspension, loss of privileges, and also looking at how far do we want to report this. Is some behavior so significant that we would want to report it to our licensing boards? Additional recommendations from the Joint Commission include developing a process to address disruptive behavior, handling many of those things that we just spoke about, and then providing training and coaching for all of our leaders. So we need to look at skills-based training and cultural assessment. Many of our leaders were not trained in what I might call conflict management, so that it's not something that's maybe inherent in all of us, so that we would need to have some appropriate training to be able to handle these situations when they come up. We want to develop a system to assess our staff perceptions of both what disruptive behavior is and also how we're handling it so that they know that we're actually handling these things seriously. We have to implement a surveillance system for detecting disruptive behavior. As I mentioned before with the one question that was asked during that one poll, is not many times it's not reported to us and then people don't report it and they think nothing's being done. So we have to have a way to appropriately have a surveillance for disruptive behavior that might be happening. So we may have an anonymous reporting system. We might want to be using our patient advocate with the complaints and comments that they receive. We might want to be doing some hospital-wide survey, include this in a patient safety culture survey that organizations are doing periodically. Or we might want to conduct some focus groups to see what are the difficult issues in our institution specifically that we might want to deal with. And then we want to look at a support-tiered, non-confrontational interventional strategies. So the goal obviously is not to suspend someone, fire someone, or take their privileges away for practicing on your medical staff. The goal is to have their behavior change so that we all have a better working environment to function in. We do need to provide support to individuals influenced by these situations. So when we have an employee, if it's one of our employees who's been affected by disruptive behavior, so if they've been in a pretty significant situation with a physician disruptive behavior or another clinician in disruptive behavior, we want to provide appropriate support to them. We might handle this in the same manner we handle critical incident stress debriefing. We want to encourage interprofessional dialogue. So if there are issues with whether a certain department in your hospital, so if respiratory therapy is having a problem with the transport department, or if it's at one certain nursing unit, the one step-down unit that is there's a conflict between, we might want to get some dialogue going between that unit and our department so that we can try to work those issues out before this does boil over and we do have an incident of disruptive behavior. And lastly, we want to document all attempts at addressing intimidating or disruptive behavior. We don't want to ignore this one and then a month from now it occurs and we say, when did that happen or what were the specifics about that? So anytime we have a reported incident of intimidating or disruptive behavior, we need to document that. So the Code of Professional Conduct, what we need to include in that, again, is what the behavior expectation is, and then also what we want people to avoid or what is considered unacceptable. So the qualities to include are that we're looking for effective teamwork, a supportive environment to work in, civility between all coworkers, encouragement between clinicians, multiple respect for everyone, honesty and cooperation. And what we want to refrain from is the sexual innuendo, abuse or harassment, any racism or ethnic slurs, violence in the workplace, intimidating behavior, foul language or shouting, being openly critical of the staff, and threatening retribution if anyone does report that conduct. The Code of Conduct, as I said, does apply to all staff and all physicians, so it does apply to members of the organization at every level. There should be consistent implementation that is essential. We cannot have a process where the hospital employees, the nurses, the respiratory therapists are more severely treated than a physician is. And we have to have leadership commitment, so from the top of the hospital down, we have to be committed that this is an important issue to us. It's a patient safety issue, and that we have responsibilities to make sure that it's enforced. And that interprofessional dialogues are so important. So whether it be between the physicians or, as I said, between the respiratory therapists and another department. This is just a list here of what I've taken from our Code of Conduct, and on the left side of the screen there, what the Code of Professional Conduct promotes a culture of safety, and I list there the what the team members are expected to do, and to address employee concerns in private, give clear instructions to patients and families, provide professional guidance to assure quality of care, cooperate with performance improvement activities, adhere to our hospital policies and procedures, promote cooperation, teamwork, self-confidence, and self-esteem in others, and respect the diversity, gender, ethnic, religious, educational, and cultural beliefs of others. And then what there is a zero tolerance for is engaging in unwelcome or inappropriate physical contact, verbal or written, foul language, and that includes email, racial or ethnic slurs, sexual comments and innuendos, and the abusive language, displaying anger inappropriately, which is throwing instruments, charts, or any other objects, humiliating, intimidating, or degrading another individual, making inappropriate entries into the medical record, and we certainly have seen that where there will be a disparaging comment about something done by another member of the team or neglected by another member of the team noted in the healthcare record. That is not the place to appropriately document that. That's a discussion to be had internally within the hospital. Acting in a manner that can adversely affect the healthcare team or the hospital itself. And then the last one is the retaliation against anyone who in good faith has reported a violation of the Code of Conduct. What we have here is basically another pyramid, and really what would be a good flow for how to ensure that we do not have disruptive behavior in our facility. And first is we want to hire excellent staff and appoint excellent physicians and make sure that professional conduct and that the Code of Conduct is discussed as one of the points of hire and one of the points of staying as a member of your staff. We need to set and communicate the expectations for appropriate behavior. Then we have to measure actual performance as we go by. We can't just set the expectation and ignore it after that. So we need to measure it and then provide appropriate feedback to that person. Manage poor behavior that we do see, and then take corrective action if there are any instances of disruptive behavior. So for managing disruptive behavior, we will develop and distribute that Code of Conduct. We'll review previous incidents in our institution to see what type of incidents have occurred so that we know the type of incident that we're talking about. A good idea also is we probably all know that there are employees that may be at risk for violations to the Code of Conduct. Not a bad idea to have a conversation with them that we know that they're at risk for having an incident of this nature, just so they're aware, so kind of that awareness conversation happening even before the event occurs. Defining disruptive behavior like we did in the Code of Conduct there, educate our staff on what is acceptable behavior and what is not acceptable, and then creating that process for managing the disruptive event if it should happen. We have to maintain unity among leadership on the intervention, so we can't be vacillating when an event occurs, and again, maybe not treating the physician at the same level we're treating the hospital staff, or not treating this staff member the same way we're treating another staff member. We need to develop those leadership skills for managing disruptive behavior, foster a team approach in the organization so that we are showing that unified front. We have to encourage reporting of disruptive behavior just the same way we're encouraging reporting of patient safety events, that it isn't something to be withheld, it's not something to avoid reporting, it's something that we want to encourage. And then we want those periodic surveys of the culture of the organization in regard to patient safety. So some of the errors in managing disruptive behavior, and certainly these are tough issues to manage, so we want to make sure that we're managing them appropriately. And the first error is that we hope the problem will work itself out and go away, so kind of turning a blind eye to the behavior and hope that it will just go away, and if we didn't hear a report of it today, then everything must be better. The next is not taking that first step. So having that first conversation, that crucial conversation, is the important first step in addressing this issue and getting a change in behavior. Next is trying to prove a staff member incompetent instead of addressing the behavior itself. So what we might see there is trying to address an employee for maybe absenteeism or a non-behavioral issue instead of addressing their behavior at that point in time. Next is use of pejorative language when dealing with behavior. So this actually leads to conflict versus resolution. So in addressing with an employer, with a physician, that there is an issue with disruptive behavior, we would want to be doing that in an encouraging way and kind of a coaching way versus coming down with a hammer in the beginning. And last on that list there is going to the bylaws or your policy and procedure manual or contacting your legal department in regard to this behavior instead of addressing it head on. And what I would call that is avoidance, that we're kind of avoiding addressing the actual issue itself by skirting around it and moving on to trying to focus on another issue. Not addressing it uniformly, and I've spoken about this several times, but it really can't be stressed enough that it's very important for as leaders, for our integrity among our staff, and also for consistency among departments and within the institution itself, that physicians and non-physicians alike, departments, units, that each unit and each department handle this consistently and uniformly. That's one thing that why administration or a higher level needs to get involved, because as we know, each manager does handle situations in a slightly different fashion. So we don't want a little coaching session to be going on for some significant disruptive behavior in one place, and then an employee is being suspended or terminated in another location for the same exact behavior. Actually, on a personal note, working on this just today, we had an incident with a nurse disruptive behavior in addressing a security guard who requested to see her identification earlier last week, and then just last evening had a physician with the exact same issue get into a verbal confrontation with our security guard. So here within 1 week we have two of the exact same issue among a nurse and a physician, and our conversation this morning in discussing both these cases is the importance of us acting uniformly on whatever the action is going to be against both individuals. Next is trying to conceal the problem from the administration or from the Board of Trustees. So that's if it's at a lower level, not letting that ratchet up so that it kind of hide it, sweep it under the rug. We don't want to do that. These are, as I said, patient safety issues, quality of care issues that are affected by this. So we want to let them out in the open. We want to be transparent and know that these issues exist. So not ignore that they exist, and then also let administration, the Board of Trustees know that we're handling them in an appropriate manner. Obtaining consultants to review or address. A lot of times in healthcare we love to bring a consultant in that if they don't solve the problem, they certainly can prolong it for a while they're studying it. And the consultants will review or address this, and maybe we'll be looking and studying hospital culture or looking at service excellence programs. To bring that in and look at the hospital overall when we know that we have an issue with a single individual or maybe one unit is not the appropriate way to address that. We really need to address it head-on with the individuals who are either high risk or have already been involved in disruptive behavior, so that we can get that change in behavior. Having a hospital-wide program to address it when we have a handful of individuals that really are responsible for it, first off, is not cost-effective, and secondly, is not going to get us the result that we want. And lastly there you see is the misbelief that disruptive behavior is forever. So kind of in that earlier poll of nothing ever changes, so why bother reporting it? We have to believe that we can change disruptive behavior, that this behavior is not something that goes on forever, and certainly that our colleagues, whether they be physicians, respiratory therapists, nurses, are able to change and are able to behave in a more appropriate fashion once they realize that, one, this is inappropriate, it's a patient safety issue, and that it's not going to be tolerated. So what I have on the screen here is 3 quotes basically that are kind of a synopsis for what we're talking about here with disruptive behavior. And the first is that we should never take away a person's dignity. It's worth everything to them and nothing to you. And certainly when you look at some of the behaviors that we've talked about, it does take away that person's dignity. And we need to respect everyone's dignity regardless of where they fall in the organizational structure and regardless of what our personal feelings are about that person. We're all co-workers here with the same purpose, to take care of the patient, and we need to respect that. And then behavior, since we're talking about disruptive behavior, behavior is what a man does. It's not what he thinks, feels, or believes. So someone may talk a good game, they may know the right thing to do, but if they're not doing that when the rubber hits the road, then that's something we need to address. So behavior, the actual behavior is what we want to look at. And lastly is he who means well is useless unless he does well. So again, it's really the performance we're looking at, not what the person means. And we've all had situations in our professional career probably where we say, oh, that's just Sue or that's just John, and that's the way they are. Well, that's not acceptable any longer. Sue or John need to change their behavior to meet our code of conduct. So anger management, there are some good references for you. Anger management for dummies, and the video, of course, with Adam Sandler and Jack Nicholson on anger management. And then we have some serious references there from the American College of Healthcare Executives and several risk management and patient safety journals where this issue has been studied and discussed extensively. And certainly the Joint Commission's website for the Sentinel Event Alert, which outlines all of the essential elements that the hospital needs to deal with. So at that point, I'm happy to conclude the program, and am more than willing to take on any questions or answer any questions
Dave,
or comments that the audience might have.
Thanks a million for a great overview of this very important issue in our healthcare system today. And I want to remind the audience that this is a good time for you, if you have not already submitted your questions, to go ahead and enter those into the discussion box there at the so we can see what they are. Dave, there was a couple of questions that came up. You had mentioned licensing boards, and one of our participants wanted to know how licensing boards are addressing or dealing with disruptive behavior.
Certainly, and I guess that would change from state to state depending on the scope of practice and also the, I guess, the authority that that board has. But I do know that specifically in New Jersey, that issues like this have been addressed, and they're actually fall into the area of kind of ethical issues. And also, one thing I didn't mention too much during the presentation was that it can be because of substance abuse, so there may be some underlying issues that are causing disruptive behavior, and that's certainly something that the licensing boards are addressing also.
Dave, has there been any research done that has actually drawn a causal relationship between disruptive behavior patterns and patient safety?
Yes, there's not real detailed information on that, but certainly the anecdotal information is that the lack of teamwork, or so the impedance of teamwork, is what causes the patient safety issues. So I don't have any hard and fast data on these events occurred because of it. But certainly when we look at, and I'd say probably if you look at the institution of the rapid response team, that probably is an offshoot of disruptive behavior and disruptive patterns that have happened in the past, where the nurse might not feel comfortable calling the physician. So we implemented a system now, and essentially it's been accepted nationwide, where where you call the rapid response team when the patient meets this criteria, and the nurse doesn't need to think, is this serious enough to call the physician? Do I want to talk to that physician now? Is it the middle of the night and I shouldn't call them? So all those issues that went through practitioners' heads are now eliminated by the
okay, I want to quickly go back to
team.
one of your previous slides. Hang on just a second. And it was the pyramid slide, which is somewhere around here, I believe. Yeah. There it is. When you were talking about this, if you look at this disruptive behavior pyramid, it almost appears like no intervention or disciplinary action or intervention really occurs until you get to the very top of the pyramid. And that kind of runs into conflict with the principle of zero tolerance that you had mentioned before. Can you kind of resolve that for us a little bit?
Sure. Zero tolerance means that we never ignore a incident of disruptive behavior, that we address every single behavior when it happens. So for example, that model practitioner who has a disruptive behavior event today, we consider that the single unprofessional incident, and we would have an informal intervention. So we aren't ignoring it, and so it's a zero tolerance. We're going to address it. But in this particular case, this is a person who's never had an event like that before, so we do the informal intervention. Someone who has a pattern of disruptive behavior, we're actually going to be having some coaching and counseling and probably provide some education as part of that awareness intervention. So again, the theory isn't off with their head. The theory is let's get them to change. So it's giving that awareness and giving them that training so that their behavior will change. The pattern persisting, we're into an authority intervention, which really I would consider then the disciplinary process probably, and the disciplinary intervention on top is either suspension or termination or revocation of privileges.
We had a couple questions from the audience I want to get to here real quickly. Hang on just a second. Let me pull those out. One of our participants wanted to know about what are the options for when your administrators are exhibiting disruptive behavior. And that seems like an odd thing, but I'm sure it happens at times. Any comment there?
Yeah, I guess the way to address that, and certainly that's very disappointing that I would hear that, but certainly it's the real world and we're all human, so I guess that is possible and probable. What I would say is there is a kind of a hierarchy of reporting of patient safety events, and I go over this in orientation every month with the new employees at the hospital, and I always tell people the first person they should go to is their supervisor. After that, every boss has a boss. You go to your boss's boss if you never got satisfaction from your supervisor. Next is to come to me as the in charge of risk management for the hospital. So that's the person, if you feel that there's a disruptive behavior that's a risk management issue, you can go to the hospital risk manager. And lastly, which is I stress is always lastly, this isn't the first approach, is every employee has the right to contact the Joint Commission, if that's your accrediting body, or the State Department of Health, who monitors hospital patient safety and quality, and report any behavior that is inappropriate. So that if there's someone at that high of a level in the organization that's causing the disruption, then the employee has every right to do that. And the Joint Commission standards do state that there cannot be any repercussions because an employee reports an event to the Joint Commission. On top of that, the Joint Commission process is completely anonymous, so you do not need to give your name when you're reporting an event like that or an issue to the Joint Commission. It's done right on the Joint Commission website, and the organization receives an email explaining whatever was entered, but there's no names included. So unless it was an event that was so specific that the hospital could figure it out, the hospital may never know who reported that particular event.
All right. It seems to me, in listening to what you had to say and some of the other stuff I've heard recently, you just can't overestimate the importance of culture, the culture of the institution in supporting all this sort of thing. And the thing that really gets that done is the leadership. And if the leadership isn't really behind this movement, it's just not going to take root and grow.
That's absolutely true. I would say that culture is slow in changing. It's the beliefs of staff sometimes is slow in changing. As much as we've been pushing a fair and just culture with patient safety, a lot of employees are still under the misconception that, I'm getting in trouble if something goes wrong. So, as much as we try to convince people that that's not what's going to happen, there's a human element involved and a cultural piece there that they feel that know that
David, this time I'd like to
issue.
direct your attention to the discussion board there, and if you would just take a look down there and see if there's any issues that you might be able to discuss in the next 2 or 3 minutes, I'd appreciate it.
Yeah. Okay. Okay, let's see. Okay, one of the questions is, if licensing boards are taking actions against practitioners or doctors, what prevents the person from moving to other locations and causing problems there? And that's actually a very good point, and that is a state-by-state issue. Luckily here in New Jersey, many of you may have heard of the Nurse Cullen case years ago, where we had a nurse that had actually been killing patients with overdoses of medications, and it was not addressed by several hospitals, and the employee was fired from those hospitals and just would go on and get a job at another hospital. And now by state law, those issues need to be reported to the State Department of Health, or the licensing board, I should say, the state licensing board. So that would be tracked, and that information would be available to for other institutions who would be doing a licensure check on that individual. We also have the National Practitioner Database, the data bank rather, and that would be another location where, again, if the hospital was vigilant and reported these issues to the licensing or regulatory authorities, that would prevent something, if there was significant behavioral issues, that person from just freely practicing in another institution. Yeah, but let's see if there's...
You have about 1 minute left, Dave, if you see anything that you'd like to comment on.
See. Okay. How are incidents handled that are documented by patients? Are complaints escalated at all? Actually, complaints, there's a very specific process that has been put in place by CMS for handling patient complaints with very strict time frames for the time frame that a complaint needs to be acknowledged and the time that a closure needs to be made on those incidents or complaints. So that is actually followed up very closely during Joint Commission survey and during CMS visits to the hospital. So I can kind of get with confidence say that complaints are being followed very closely from the regulatory side to make sure that hospitals are not sweeping things under the rug. And then we do have a much more savvy consumer out there than we used to. So the consumers do realize that they can report something to the Joint Commission. I do periodically get a patient issue raised from the Joint Commission, and certainly they do know how to get a hold of the State Department of Health and know that they regulate hospitals, and complaints or concerns are voiced to them, and the state agencies do investigate them. So there is Big Brother is watching as far as patient comments.
Well, Dave, I again want to thank you for just a wonderful presentation today. And I'd like to, for those of you that are watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.